Hello everyone, my name is Dr. Mishal Munir and I'm currently pursuing my journey for internal medicine residency. So, the topic of discussion today is understanding plasma cell dyscrasias, a clinical guide. We'll be discussing certain types of monoclonal gammopathies, which, as you all know, includes smoldering myelomas, multiple myelomas, monoclonal gammopathy of clinical significance, MGUS, which is also known by monoclonal gammopathy of undetermined significance, monoclonal gammopathy of renal significance, and Waldenstrom macroglobulinemia. Now, first, we'll be discussing on how to remember them easily because it might be getting a little bit complicated a lot of times. So, I will be making it easy for the viewer to actually understand them and remember them. We'll be discussing about the importance of these monoclonal gammopathies and including when to ponder over for an M protein in a patient, with what symptoms they come when we need to look over for the M proteins, and we'll be discussing about the impairment of the free light chain ratio in a patient with MGUS and in a patient who does not have any plasma cell dyscrasia but just has a chronic kidney disease. So moving on. So these are a few easy ways to remember them. So we'll be starting with multiple myeloma. As you all know that it's a blood cancer that's characterized by M protein plus CRAB features. Now this CRAB feature has been updated to slim CRAB features. I will be telling the detail of this in the later slides, but for your guidance, it's basically that the CRAB, it's a mnemonic which stands for calcium elevation, renal insufficiency, A for anemia, and B for bone marrow disease. With SLIM, it's S for 60% plasmacytosis, and L stands for the light chains. Then there's going to be M, which stands for MRI, which includes one or more focal defects. We'll be getting in detail later. Then we have plasma cell leukemias. Now, as the name indicates, it's an aggressive form of myeloma where there are high levels of plasma cells that are circulating in the blood. Then we come with two very distinctive terminologies, which has MGUS and MGRS. MGUS is basically the gammopathy of undetermined significance, and MGRS is basically the gammopathy of renal significance. So, undetermined significance is when there is M protein, but there's without symptoms. There's a very small percentage of individuals who go on to develop myeloma or amyloidosis or Waldenstrom macroglobulinemia, those who have this MGUS. This is going to be basically the patients who have an elevation in M protein, but they're without symptoms. I'll tell you how to differentiate between these two furthermore in detail in the slides ahead. Then there's MGRS, which is a monoclonal gammopathy of renal significance. Now this means that there's an M protein elevation plus there's renal damage, but again it does not meet the diagnostic criteria for myeloma. We have smoldering myeloma. Again, there's a higher burden of disease than MGUS, but lower than myeloma. So there's a percentage which actually distinguishes smoldering myeloma from multiple myeloma and MGUS. We'll be talking in detail ahead. Then there's plasmacytoma, which is, as you might know it already, it's a tumor that's made of plasma cells, but it does not, and it might as well turn into myeloma. Then we have AL amyloidosis, which is the light chain amyloidosis that misfold into amyloid proteins. They're always Congo positive, stained red positive, and they deposit into different organs and they cause damage. There's Waldenstrom macroglobulinemia, which has significantly IgM protein, lymphoplasmacytic cells that are different pattern of symptoms, and there are different pattern of symptoms than myeloma. Then we have POEM syndrome, which is again, POEM stands for P for polyneuropathy, O for organomegaly, E for endocrinopathy, and M for monoclonal proteins, with S for skin changes. Cryoglobulinemia, which is the precipitation of immunoglobulins at cold temperature, and then we have the deposition disease, which can be a light chain or the heavy chain, depending on what is depositing. It is actually the deposition of these heavy or light chains into various organs. So, talking about the importance of monoclonal gammopathies. Now, MGUS is very important because it's relatively highly prevalent in the general population. And there's always a risk of this to progress to plasma cell malignancies, which can include various forms. For example, multiple myeloma, light chain amyloidosis, or Waldenstrom macroglobulinemia. It also has a causal association with several serious non malignant disorders, and there's always high frequency seen with aging. So, these are certain things that are commonly detected in normal clinical practice. Now, talking about what is an M protein, it's basically a monoclonal immunoglobulin, as we all know, that is secreted abnormally, and they're expanded clones of plasma cells that are produced more, which is actually produced more than the normal amount that they're supposed to be produced. Now, it may contain a heavy or a light chain, an intact immunoglobulin. It can be only light chain, which is like, as the name indicates, with certain things that we come across, like light chain myeloma. Light chain myeloma is that there's an increase of light chain only, or light chain deposition disease, or AL amyloidosis, which is significantly consisting of light chains only. Then we have heavy chains, only diseases which can include like heavy chain disease, for example, heavy chain deposition disease. So we'll be talking about when to ponder over for M protein, as I discussed earlier as well. So for multiple myeloma, again, if a patient's coming with symptoms with CRAB, along with that, I'll include slim CRAB features. Um, Again, CRAB criteria indicating hypercalcemia, renal dysfunction, anemia, lytic bone lesions, and for the slim, it means 60% plasmacytosis. L stands for light chains. That's the ratio is more than 100. And then with M, it stands for MRI, one or more focal lesions. That's when I will be pondering over for an M protein if a patient is coming with these symptoms. Then we have if a patient comes with peripheral neuropathy and an organomegaly that is found clinically, we might think as it can be a Poems syndrome, it can be AL amyloidosis, and it can be Waldenstrom macroglobulinemia as well. What we're going to do is that we're going to go and check the M protein levels. Then, if there's a patient coming with symptoms of hyperviscosity, for example, there's constant headaches, there's blurry vision, there is lightheadedness at times, and there is shortness of breath, we might think of a Waldenstrom macroglobulinemia. Then, if there's a patient coming normally with the heart failure and there's no actually specific cause of a non-ischemic cardiomyopathy on echocardiographic findings, and it is suggestive of infiltration as well, so we might think that there might be a case of cardiac amyloidosis. Apart from that, if there is unexplained renal failure, there's proteinuria, there's hematuria, and plus there's unexplained anemia, it can be monoclonal gammopathy of renal significance. As the name indicates, renal, so it has to be an unexplained renal failure that has to be there. Then, if there's a gamma gap that's elevated, that's again the reason is that we have to see if the monoclonal protein is elevated or not, and if there's an urticarial rash. There's a thing that's called as Schnitzler's syndrome, which predominantly consists of an increase in M protein along with the patient who complains of urticarial rash on and off. So here we can see the plasma cell, and you can actually see how gorgeous does it look. But eventually, when it will be actually the picture on the right hand side makes you see the scarier version of the plasma cell, which is when we need to get worried. Now, moving forward, we'll be discussing about the IMWG criteria for diagnosis of myeloma. As I stated earlier as well, that there's a diagnostic criteria which is responsible for differentiating between MGUS, smoldering myeloma, and active multiple myeloma. Apart from the other features, the one most important or distinguishing thing is that you need to remember always is that whenever there's MGUS, right, monoclonal gammopathy of undetermined significance, less significant, always remember less than 10% of the bone marrow is involved. Now, there are two extremes. One is MGUS and one is active multiple myeloma. So the easier way to remember is that always remember, okay, if it's MGUS, it's less than 10%. If it's multiple myeloma, it's more than 60%. And if it's smoldering myeloma, the only thing that's left is the in between one, which is that the clonal plasma cells in the bone marrow are more than or equal to 10% to 60%. So less than 10 is MGUS, 10 to 60 is smoldering, and more than 60 is multiple myeloma. Now, this is one way to differentiate it, and which is the most important thing to remember always. Other things is that with MGUS, as the name like indicates, it's undetermined significance. Patient is not symptomatic, so the M protein is going to be less than 3 grams per deciliter. Now, there's no myeloma defining event as well, right? Smoldering, on the other hand, is something that's, there's a clonal plasma cell that's there's the concentration is between 10 to 60%. So what I'm gonna think is that, okay, the M protein is more than 3 grams per deciliter in the serum, or if I talk about the urine for 24 hours, it's more than equal to 500 milligram. But again, there's no myeloma defining event. But when it's active multiple myeloma, as I say, it's actually highlighted in a red color, because the reason I did that was because, yes, now this is something that we need to look over more. Not that you're not going to be pondering over MGUS or smoldering myeloma, but still, again, it's going to have more than 60% of the clonal plasma cells in the bone marrow, along with the slim crab criteria, which you can read on the slide, and I've mentioned it earlier as well in detail. So that is the criteria, how to distinguish between MGUS, smoldering myeloma, and active multiple myeloma. So now, what are the diagnostic tests for monoclonal gammopathies? So we have SPEP, UPEP, it's serum protein electrophoresis, urine protein electrophoresis, serum immunofixation, urine immunofixation, and again the kappa lambda ratio, which is the serum free light chain ratio. Now, always remember this thing that serum protein electrophoresis and urine protein electrophoresis will tell us if there is an increase in the quantity of immunoglobulins, but it is not going to be defining what sort, of the immunoglobulin. It's IgA, IgM, IgD, IgE, whatever it is. For that reason, we do immunofixation. So immunofixation actually helps in it actually helps in determining the quality rather than the quantity. But serum SPEP and UPEP, they're mostly for the quantity of the immunoglobulins. We'll be talking in detail later in the later slides. So we'll be talking about now we'll be discussing what is immunofixation. So again, it helps us to identify the isotype, IgG, IgM, IgA, or IgD. It's not a quantitative test. Instead, it tells the quality. It's a qualitative test. And it identifies the antibody against heavy chains, kappa and lambda light chains, and it also helps in detecting small proteins which might be missed on electrophoresis. So Now, talking about the prevalence in general clinical practice, now diagnosis of MGUS is most often incidental, and it's made by non-hematologists. It's common, and plasma cell dyscrasias or malignancies are very rare, like more than equal to 35,000 new cases annually is what we see. The chances of identifying the plasma cell malignancies that are like in day-to-day practice very low. It's estimated that on average in USA, a hematologist oncologist sees like two new multiple myeloma cases annually and one new case of AL amyloidosis or Waldenstrom macroglobulinemia every 10 years. So these numbers like are expected to be far less in general medical practice than reality, but this is how it is. Then talking about the risk stratification of MGUS. Now we have Mayo Clinic model, which is responsible for stratifying the risk factors. And then the absolute risk of the disease progression over 20 years for patients with various combination of risk factors. So I'll be talking about this now. The risk factor of Mayo Clinic model, it basically, the foundation of it is the quality, the quantity, and the ratio. So talking about that, if we talk about the quantity, so that means that, if the serum M protein level is more than or equal to 1.5 gram per deciliter. If you're talking about the quality, that is like if it's a non-IgG gas, that is it has IgA, IgM, IgD. And if we talk about the ratio, it means that if there's an abnormal serum free light chain ratio, that is ratio of kappa to lambda free light chains less than 0.26 or more than 1.65. So what's the absolute risk of progression over 20 years for patients with this? If there are three risk factors, which are stated above, it's a high risk MGUS, so it's going to be around about 58% chance of it to progress over 20 years for the patient. If it's two risk factors, it's high intermediate risk MGUS, that's like 37% chance. If there's one risk factor, it's low intermediate risk, that's 21%. And if there's no risk factors, it's low risk MGUS, that's less than 5%. So, in general clinical practice, there's an abnormal SPEP is found in up to 5% of the population. And there's another thing that serum proteins normally they increase with age as well. So, if it's tested inappropriately, it can lead to serious consequences because a normal human being as well, without any plasma cell dyscrasias or underlying plasma cell malignancy, the serum proteins are expected to rise with age as well. So, that's about it. So, when screening for MGAS, there's a study which is displayed on the screen in front of you. You can actually go and look at this in detail as well. So, this study, it's basically the screening of for monoclonal gammopathy of undetermined significance. It's basically an iStop study which was done. And the results that indicated from the study was that it's an Icelandic study with 75,422 participants that was screened for MGAS. And out of those, 4.9% had MGAS. The median age of individuals when they were diagnosed or discovered with MGAS was 69. And most individuals with MGAS had either low risk, that's 38%, or intermediate risk MGAS. High risk MGAS was only 0.2% of the MGAS cases that we see. So the progression rate, as told by this study, it's like literally the high risk MGAS progression. I mean, the progression rate for people to go with the high risk MGAS is literally way less. That's less than, I mean, it's 0.2%, which is quite less. So the next question is that how to monitor for MGAS. Now, if a person is coming to us with suspected MGAS, what are the next steps to be taken? Let's see if the person is low risk, that means that's less than 1.5 grams per deciliter, IgG type, and if it's the normal FLC ratio. Or if it's IgM, which is less than 1.5 grams per deciliter, or if it's light chain MGAS with FLC ratio less than 8. If these are the three criterias and the person, if these are the three criterias and when any one of them is met, so that means it's an uncomplicated case. So what we're going to do is that we're going to be deferring with the bone marrow biopsy and skeletal survey. If apart from these three criterias, there's a presence of unexplained symptom or a laboratory feature of concern, then we might go for a bone marrow biopsy. because that is required, and we'll do a low dose whole body CT, that's a skeletal survey or conventional radiographs required in non IgM patients. And all the other patients who do not meet this criteria, the one that is written on the left hand side in the upper box, for them we go with the bone marrow biopsy, that's a must, and a skeletal survey as well. So another thing is that how do I follow MGAS in clinics? Now, all patients with MGAS, they need to follow up in 6 months. So we'll be seeing if there's a possible progression or if the patient is stable. If there is a possible progression that we see, we'll work up for lymphoplasmacytic malignancy. If there's a malignancy, we'll manage accordingly. If there's none, then we'll go with annual MGAS follow up, which includes the calcium levels, creatinine level, CBC level, definitely SPEP, and the free light chain ratio. If the patient is stable, we'll stratify the risk. Risk stratification, we'll do that, which I mentioned earlier in the slides as well, according to the Mayo Clinic model. And we'll see if the patient is low risk or intermediate or high risk. Again, if it's intermediate or high risk, definitely, because there's a chance, we'll go with an annual MGAS follow up that includes CBC, calcium, creatinine, SPEP, and FLC. But if it's a low risk, we don't need to follow up for MGAS. We'll go with the usual medical care. So if you see this slide, that what are we most concerned about in MGAS? Obviously, the first and the foremost thing that we're concerned about is what are the chances of MGAS or smoldering myeloma to progress to multiple myeloma? So if you see the two graphs in front of you on the screen, the right-hand side and the left-hand side, let's just say, I'll just assume like 10 years from diagnosis with MGAS, the probability of progression is 10%. Whereas 10 years from diagnosis of smoldering myeloma, the probability of progression is 66%, which is a huge number. So you can see the difference evidently for the chances of progression of MGAS and smoldering myeloma to multiple myeloma. Now we'll be talking about the types of MGAS and pattern of progression. So we have three subtypes of MGAS. This is IgM's MGAS, non-IgM, and then there's a light chain MGAS. The diagnostic criteria, the risk of progression, and the patterns of progression are also seen. You can see it on the screen in front of you. With like the IgM MGAS, the diagnostic criteria is that all the three criteria have to be met. The serum IgM levels need to be um, less than 3 gram per deciliter, and the bone marrow lymphoplasmacytic infiltration less than 10%, and there's no evidence of anemia or any other constitutional symptoms like lymphadenopathy or organomegaly or anything of that sort. The risk is 1% to progress, and then pattern of progression normally seen is Waldenstrom, AL amyloidosis, or rarely IgM type multiple myeloma. Talking about the non-IgM type multiple myeloma, again, the three criteria need to be met. That means that the non-IgM type immunoglobulin, like the monocular protein, has to be less than 3. The clonal bone marrow plasma cells need to be less than 10%. And there has to be an absence of, again, the end organ damage, such as, hypercalcemia or any CRAB features. The risk of progression is 0.5% per year. And the pattern of progression will be multiple myeloma, solitary plasmacytoma, or AL amyloidosis. Then we have light chain MGAS, which is that, again, these criteria need to be met, which includes the FLC ratio needs to be less than 0.26 or more than 1.65. Then we have increased levels of involved light chain, that is increased kappa free light chain in patients with FLC ratio more than 1.65, and increased lambda FLC in patients with FLC ratio less than 0.26. Then there has to be no immunoglobulin like heavy chain expression. It has to be significantly light chain. Then absence of any end organ damage or any plasma cell proliferative disorder. And then again, the same criteria, which is the general criteria. The clonal bone marrow plasma cells need to be less than 10%. And again, the urinary monoclonal protein needs to be less than 500 milligram per 24 hours. The risk of progression is 0.3% per year, and the pattern of progression normally that we see is light chain multiple myeloma and AL amyloidosis. So, what are the signs and symptoms that actually indicate a possible progression? The unexplained features like anemia, diarrhea, fracture, cardiomyopathy, normal restrictive, organomegaly, hyperviscosities, again, intestinal pseudo-obstructions, macrogracia, renal involvement consisting of nephrotic, then neuropathy, autonomic sensory or motor purpura or renal insufficiency, monoclonal protein studies, which is like serum M protein IgG or IgA, that's more than or equal to 3 gram per deciliter, urine protein M protein, that's more than 100 milligram in 24 hours, and serum kappa or lambda free light chain, that is more than or equal to 100 milligrams per deciliter, and involved and uninvolved free light chain more than 100. Then there's 50% increase in serum monoclonal proteins, absolute increase of more than or equal to 0.5 grams per deciliter. So there are a few interesting facts which are seen. Basically, there's a serum free light. We'll be talking about the serum free light chain ratio in a person with chronic kidney disease. Now, immunoglobulins again are made by normal plasma cells. So, free light chains, they are produced in excess of heavy light chains normally, and excess polyclonal free light chains are then released into the serum. Now, they're rapidly removed by the kidneys. So, half life is normally like 2 to 6 hours, but if the creatinine clearance falls, it is only expected for these free light chains to rise because the kidney function is getting deranged, right? Now, what would happen for the serum free light chain ratios in CKD? Now, you would expect that in renal failure, due to non like monoclonal plasma cell cause, it results in a proportional rise of both kappa and lambda with the preserved ratio because they're not getting cleared from the kidney, but that's not actually the case. Normally, what happens is that the kappa free light chains, they're produced more often than lambda. But what the structure of lambda is that it is more heavier. It forms dimers, so it actually doubles the molecular weight and it actually slows their renal clearance as well. So in a normal situation, kappa lambda ratio is actually usually slightly less than 1 since lambda sticks around in blood more than kappa. But when there's a kidney dysfunction, the reticular endothelial system becomes an important route for clearance. Now, this route is not influenced by the weight of free light chain. The median kappa lambda FLC ratio increases with CKD stage. Hence, the serum ratio, it starts reflecting the higher kappa production rate as the GFR decreases. So that's why this is the reason that most MGUS consults in patients with CKD have a kappa light chain higher than lambda because lambda again is a heavier in weight and normally forms dimers, takes longer time to get cleared, and hence an abnormal ratio even though there isn't really a monoclonal cause is seen. So, summing it all up, the kappa lambda ratio goes up with CKD. And we've taken data from an iStop MM study. It's a large screening study that was used to develop new FLC ratio reference intervals adjusted according to the glomerular filtration rate because it got hard to actually distinguish that whether the patient is having a chronic kidney disease, which is the reason why for the kappa lambda ratio to get impaired, or is it a monoclonal cause that is the cause for that. So for that reason, we came up with the study and we came up with these reference ranges according to the GFR. So if it's 45 to 59, the FLC ratio reference interval needs to be 0.46 to 2.62. So these are like adjusted according to the GFRs, as you can see in front of the screen. I've tried to give in the link at the bottom of the screen as well for you to actually go and look yourself for this study for yourself as well so that you can have a better idea and you can actually study in depth and detail. But patients might be misclassified as having a kappa monoclonal gammopathy because of an increased kappa lambda ratio solely due to kidney impairment. And again, patients with lambda monoclonal gammopathy along with kidney impairment might have a relatively normal kappa lambda ratio. And we missed because of the relative increase in kappa chains due to the kidney impairment. So, kappa lambda ratios more than 3 are unlikely to be due to kidney impairment alone. And this is the ISTOP-MM study, which was published in November 2023. So there are revised reference intervals for the serum free kappa free light chain and lambda free light chain and FLC ratio according to the age now. They've added the factor of age in it, and as you can see in the table in front of you, if it's age less than 70, more than equal to 70, there are certain kappa and lambda free light chains and the free light chain ratio intervals that are given. For a more thorough look and a more thorough concept, you can actually go and look up for the study and find more details about this. But due to the shortage of time, this is the max I would be able to explain here. I hope I did try to help in some way, and I did try to clear some concepts and some misunderstandings that were there already. Thank you so much.